The 52-year-old man presents to the clinic with increasing fatigue, muscle weakness, weight loss over the past 3 months. He also reports of feeling dizzy and lightheaded when standing up. He has a history of rheumatoid arthritis, an autoimmune condition, and is on long-term methotrexate therapy. On physical examination, his blood pressure is low and his skin appears darker than usual. That means there's high ACTH production, low BPs. We are looking at a picture of primary adrenocortical insufficiency because that's when you have a high ACTH. Laboratory findings include low sodium, elevated potassium, low morning serum cortisol levels. ACTH stimulation test shows inadequate cortisol response. What is the most likely cause of this patient's adrenal insufficiency? So clearly, this is primary adrenocortical insufficiency. If you were to do an ACTH test, you would find that the ACTH level would be very high. So this is primary adrenocortical insufficiency. And the risk factor here is the rheumatoid arthritis being an autoimmune disease. So it's at risk of having other autoimmune diseases. So you might have autoimmune cause of the primary adrenocortical insufficiency. Let's look at the answers here. Autoimmune adrenalitis, that's the most likely answer here. But let's look at the other answers. Rheumatoid arthritis induced adrenal insufficiency. Rheumatoid arthritis induced adrenal insufficiency. It doesn't really make sense. This one, the first one, actually throws more light on the pathophysiology of what is actually going on. This is just a broad term. So A is more suitable than B. Pituitary adenoma causing secondary adrenal insufficiency, no, because with that, even the ACTH stimulation test, you may have some adequate cortisol production. And also with that, ACTH should be low, so you will not have hyperpigmentation. Drug-induced adrenal suppression due to methotrexate. Adrenal suppression usually is due to giving exogenous glucocorticoids. Methotrexate actually causes liver issues, not suppression of adrenals. Then we have tuberculosis-induced adrenocortical insufficiency. There's no history of chronic cough, night sweat, no contact with chronic cough patients or anything like that in the history. So most likely our right answer is the A. So A is the right answer as explained thoroughly.